Thank you very much for having me. I'm Natasha Gatson, and I'll be talking about extending quality living and identifying at-risk vulnerable patient populations who would be more amenable to CNS brachytherapy. I have a relevant disclosure as I am a consultant for GT Medical Technologies, and I'm the founding president and CEO of Neuro-Oncology, a nonprofit educational foundation for patients with tumor. So I went to Indiana University undergraduate, and Indiana has both rural and urban sort of populations. I went on from Indiana University to go to the Ohio State University in Columbus, Ohio, where I obtained an MD, PhD. I also did my PhD in molecular virology, immunology, and medical genetics before doing my neurology residency and a postdoctoral fellowship in neurosurgery. At Ohio State, we have more urban populations, but also some quite rural and Appalachian vulnerable patient populations. I learned a great deal there in my 15 years at that institution before moving to Houston, Texas, to study and do my Neuro-Oncology fellowship at MD Anderson Cancer Center. I was there for 2 years and took my first faculty position in one of the largest rural health systems in the nation at Geisinger Health, where I worked as an assistant dean for equity and inclusion, but also directed neuro-oncology. This patient population has about a 4% e-migration rate, so 96% of the people in this area, very rural area in Danville, Pennsylvania, and its surrounding 67-something counties in Pennsylvania, with primarily rural patient populations. These patients have to deal with vulnerability issues that are not just related to access, but also related to the geography and being able to get into certain centers and have access to virtual visits as well. Finally, going back to the MD Anderson family, I went to Banner MD Anderson in Phoenix, Arizona, where one of the rural populations, one of the more vulnerable populations there had to do with the Native American population. And a lot of those different populations rely on their communities to support some of the financial, medical burdens that they may experience. Those patients come from reservations and consider standard of medicine, and as we practice it in the United States, as Western medicine. So there's a lot of hesitancy when we talk about vulnerable populations. For them, we're dealing with a lot of hesitancy and distrust in the system, but also some access issues and cultural and values. So I've really gotten a great opportunity to experience a good number of patients and what things influence their decision making, and how, as a good practitioner, to be able to respect those values, understand geography and human geography, and what things may influence their ability to be able to access certain parts of care. I currently, as described, I currently work at Indiana University, so I'm back in Indiana, and I am the director of the Center of Excellence here, focusing in on both rural, again, and urban populations, but now I've taken a special interest in understanding our VA patient population. And these patients have their vulnerabilities similar to all of those that I've described previously. So I'll start with my care philosophy. My care philosophy is that treatment should be compassionate, evidence-based, and grounded in quality. So compassionate treatment is treatment that is not worse than the disease itself. If the disease is not making you as ill as the treatment is, then the treatment is wrong. When I think about evidence-based, I'm talking about precision medicine, focusing on the most individualized care that you can offer and still get best outcomes for patients. Finally, quality. Physicians, we hear it all the time, that we are saving lives, that we're lifesavers. The truth is no. My goal is not to save a life, because we cannot save a life. Instead, what we can do is aim to extend that life with some quality and allow them to live as well as possible for as long as possible. Life is not short as we frequently hear, from the time that you're born to the time that we die, that's life. It's the longest thing you're ever going to do. And with that being said, we understand that living then becomes the part that is short. And that's the time with loved ones, the time that you have in your career, the time that you get to live and breathe and experience the world around us. And that is the living part of it. And while all of us die, the question becomes, how can we make it so that we live? And in enjoying that part of our life that is living, how do we make sure that we, as physicians, are aiming to offer the highest quality in that living time? So when I talk about some real-world experience considerations, I'm talking about the things that I've used to evaluate patients. And so we know how to identify the patients that are well in line with the indications for use of CNS brachytherapy. Then that's talked about quite frequently. But my goal is to recognize susceptible patients, patients who have layered, complicated histories and things that may make it so that these patients may further benefit from CNS brachytherapy and with improved outcomes. And we talk about improved outcomes, it's not just survival. This is about quality survival and their progression-free survival. So we think about the things that make our patient population vulnerable. So it's easy right away to identify issues with transportation and how the transportation may be a financial toxicity. Patients that may have to be placed in gurneys and transported using special vans or vehicles, that may be difficult. Patients that have to come from 150 miles to get into the main center that has certain treatment options, that could become part of the complication. Access, the number of physicians or providers in an area offering a particular type of treatment, that may be the difficult part. Having the support around you, mobility. The patient may be able to get all the way to the center, and the center could be 5 minutes away, but being in a wheelchair or a walker or having some other limited mobility issues, this may cause the toxicity, especially when we think about patients that have to get standard radiation. And that is, if it's the treating a GBM, this is 6 weeks of trying to make the transportation and mobility complication possible. We think about things that may make a situation more urgent for a patient, or things that may cause a patient to not adhere to the process. If the process is too complicated, we can be certain that non-adherence is going to be an issue. But then we have to fill in the most important parts, is what's compassionate and what aligns with the patient's values. If the patient values not having to get up every single day and going into the hospital, or if they value that much of the time that they have left is not going to be with a great amount of quality, or the time that they have left is very limited, it may be that they choose to take options or make healthcare decisions that are in line with maximizing the punch in the smallest amount of time. So these are some of the things that I think about. So when I talk about mobility, this is the significant travel complication for a patient. I gave the example of someone being able to have the appropriate vehicle, and maybe they have the financial means to make all of those things happen. But what if when they get to the location to get the treatment, mobility is painful, or they cannot tolerate being able to be moved back and forth from gurney to a seat, or gurney to chair, gurney to table? Those things we all have to think about. Or what resources would it require? How many people are required to transport this person? So those are all the things that I calculate when I'm thinking about this mobility. So herein lies the first risk to non-adherence. And then we think about the values. So here I show a 77-year-old patient with a great functional score as far as their physical abilities overall. It's not too low, 70%. And we look at the imaging here, and you can see that this patient may have some cognitive issues. Definitely, this is a glioblastoma, very large, and the surgery is going to be a large, complicated surgery. But the patient also having seizures and their values, what they describe to us. Now, we can look at this and start to assume how much time this person has, but we ask the patient about values, and their values are, I would like to be homebound as much as possible. I want to enjoy the time that I have in my home. So in aligning with those patients' values, I have to think about all of the other things that were already running through my mind when I saw the imaging prior to surgery. This patient has tumor characteristics that automatically tell me that this is probably a bifrontal GBM. So there's a poor prognosis. The patient is elderly, and even before starting and moving into surgery, we saw that this patient was having cognitive decline, issues with seizures, and not able to do all of their own activities of daily living. We know that this patient is probably somebody who is going to benefit from having you taking advantage of an innovation such as CNS Brachytherapy that may limit the amount of days outside of the home, and that may also make it so that this patient, that we align with the values of the patient, the best wishes, but also offer high quality care. So we can extend the quality of the living time, first by thinking, how do I follow the values? Then we think of issues of urgency, when time is brain. Here's a patient with an even better KPS, Karnofsky Performance Score, of 80, 3.5 weeks after they had a near gross total resection. The repeat imaging, as we're getting ready to plan for the radiation, shows 80% regrowth of the tumor. So in that 3.5 weeks, the standard amount of time that we wait before starting for external beam radiation type therapy, or IMRT, these patients come into us, and we call these patients that rapidly progress. 3.5 weeks, 80% of this is regrown. This is a patient where every moment that we take is loss of brain and potential loss of neurologic function. This is a great patient in my real world experience to take back to the surgical, back to the operating room, and place CNS brachytherapy, GammaTile. And in this particular case, that is how we proceeded with the patient after a discussion. And then we think about access. So in this picture, you can see this is maybe a more rural area, and we have the providers that are standing in the divide between the more urban centers. And we think about the geography that makes it difficult, even living here, to get from point A to point B. But when we think about the geography here, that makes it difficult to traverse this, to get to the centers where you have to get this therapy done. We have to think about the weather and the climate, the other things that may make crossing this divide difficult. And so getting to this specialized care, and even having the health literacy, understanding the value of that specialized care. I often get patients that will ask questions of us about, can I just get the radiation done at any radiation center? And you have to sort of work to help patients understand that that specialized care, and sometimes care that offers innovations, have to be done initially at a single location, but the follow-up for that care can be done closer to home. So we think about those things, and I make sure that that's a part of the discussion. The alternative for the patient that may have to deal with coming back and forth from a rural location to an access center is that the patient does 6 weeks. And I've actually been put in some of these situations where it would be too difficult for the patient to get back and forth, and there's a financial burden. We would have to take that patient and admit them to the hospital for the duration of the 6-week IMRT radiation. And you can imagine the financial burden, what that hospital bill will look like, and also the financial burden to the institution. But when we think about the families that have to deal with those situations, we understand that employment may be an issue. While this person, under normal circumstances, could go back and forth and still go to work, and with IMRT and still go to work, the patient now being away from home and in a hospital setting is now not going to be able to participate in employment. But imagine also, too, how far away this person is from the rest of their family of origin and their central family, central support systems. These are things that we have to think about with these patients. And so looking through all of those different access, mobility, transportation issues, and when time is brain, when there's urgency, or when the values can potentially guide the physician, those are all the things that I summarize and I look at our VA patient population. In Indiana, the VA Health Center is quite large. There's 15 locations, with 13 of those being outpatient clinics. They network and they combine with Michigan, Ohio, Indiana. Indiana will also combine with Ohio, Michigan, and Kentucky and partner in some of their initiatives. And so when we get one VA center on board to do or offer a particular type of service, we make sure that in this region, in this area where we can access all these patients, we do the outreach and make sure that those patients are aware. This is why I'm working so hard to get CNS brachytherapy in these areas, because it would mean a lot to the neighboring towns. 62,000 veterans yearly, and you can see the number of outpatients and surgical procedures. So clinically and education-wise, you'll see that there's an extensive network and reach across the entire state. When we look at the active research and the protocols, the number of research investigators within the Indiana healthcare system, VA healthcare system, and their research budget, their commitment to cancer is tremendous. And we have an opportunity when we're working with innovations and innovative organizations such as GT Medical Technologies to be able to introduce research and active ongoing studies. That's another way that we can help our patients in the VA system. And you can read this here about how we educate trainees. So when I think about the vulnerable VA patient population, all the things that I mentioned before, they are more likely susceptible to issues of access and the issues of mobility. But they're also limited by their complex health system and the health, funding for healthcare. A lot of the things that we have to order as physicians, whether we're working within the VA or outside the VA, we have to make sure that MRIs or certain formulary medications, all these things have to be approved through the VA health system so that they're paid for and we don't cost this patient a financial toxicity. But another very, very important point to make when we're working with our VA patients is that they're strong values and that they have complex medical histories. A lot of times I meet the veterans, and one of the most important things for them is to remain homebound, or at least not in the hospital. And if I could help them design a pathway and laying out, so sort of charting their course for treatment and laying that out and making sure that I stay the path for them, it has a lot to do with their strong values. A lot of times you don't get patients from the VA that will complain a great deal about the pain that they're suffering, getting up from a chair and moving over to an area for the radiation or moving over to an area to be treated. These patients tend to feel as though they have to deal with it and that they have to move forward. But I ask the question as a physician, right in the front when I meet them, what are your values? What are some of the things that you imagine for end of life and how that looks? What things get in the way, and can I offer social work support to better identify any potential financial or transportation toxicities, as well as housing, food insecurity? We deal with a lot of these things for these patients. And so if we're doing the bigger picture and we're taking care of the whole patient, making sure what things make them vulnerable is ideal for me. This falls right in line with when I'm offering for my patients the potential to have GammaTile placed, along with the well-known indications and the FDA approvals for this therapy. I add in what I know to be great values for these patients when I'm fighting to make sure that the insurance companies move forward, or that this is an approved approach for patients. So be very happy to partner with anybody, especially those who are working to bring this type of technology and therapy to our patients in the VA. Have a great day.